So, got it. Good afternoon. My name is Dan Andrus. I am the director of the Substance Use Disorder Treatment Project at the Foundation for Healthy Communities. And it's my pleasure to welcome you to this afternoon's presentation by Carol Furlong. Today, we're going to be talking about levels of care, getting our patients to the right place. And I'm very excited about that. The hospital system's addiction care community practice promotes the development of interdisciplinary hospital systems that identify, engage, treat, and coordinate services for people with substance use disorder to improve patient and hospital outcomes in New Hampshire. It is funded by the New Hampshire Department of Health and Human Services and the Bureau of Drug and Alcohol Services. It's coordinated by the Foundation for Healthy Communities and Growth Partners. I'll take that opportunity to spotlight Lindy Keller from the Bureau of Drug and Alcohol Services, who is our project officer and a champion for this work. And welcome Lindy, and also Growth Partners, who are the people behind the scenes here. I commented to them this morning that it may take a child or a village to raise a child, but it takes the entire Growth Partner staff to keep this baby boomer on track. And we welcome you, Stephen Clark, Mona Rose. Many of you will remember Mary Ellen Shannon, who has left Growth Partners for other opportunities, but we have an outstanding team backing us up here, and we deeply appreciate all of their help and more. Today's meeting agenda is that we will move quickly through some introductions, and then I will turn it over to Carol, and she will share some insights and what I think will be some very good information for you. So we will move into her about 2:25 or sooner if we need to. We will break off and do some closing announcements, and we will very much appreciate your time this afternoon. With that in place, it is my great pleasure to introduce my friend and hero in the area of substance use disorder, Carol Furlong. Carol recently retired from Elliot Hospital, and nobody noticed, because Carol is continuing her work there as a consultant in substance use disorder and mental health. She has been in this field for 40 years. She's had a special affinity for people who are homeless and for veterans and for persons who were formerly incarcerated. She is known throughout the state as a champion of stigma reduction, and she is also a faculty member at Riviera College and Springfield College. Carol, if I missed anything, you can fill that in, but it's my pleasure to turn the time over to you, and I will go on mute.
Thank you so much, Dan. Just as an aside, you're right, I retired and some people didn't notice. And then there were other people who went to my boss and said, I thought I heard Carol retired, but I'm still seeing her everywhere. And I suggested to my boss that she should have said, I know, we just haven't been able to get rid of her. So that might still come. So today we're going to talk about level of care. How do you choose the correct level of care, and how do you make those decisions? The learning objectives are to identify and apply 5 signs of quality treatment. These are very basic criteria in order to really start evaluating some of the resources that you have. To identify and utilize 6 dimensions of a level of care assessment and their components in order to effectively refer clients to treatment, and then to identify the levels of care for substance use disorder treatment, ensuring appropriate referrals and facilitating successful treatment outcomes. Next slide. So one of the purposes, why are we doing this? It's because people seem to, I think at times, just say, I need to refer someone to treatment. I've heard about this place, without understanding what's necessary, what the criteria are. And we certainly want clients to receive the most appropriate care, but just as importantly, we want you, the providers and the clinicians and the staff, to feel comfortable and knowledgeable about where you're referring people. So what's the issue? In 2020, more than 41 million Americans were classified as needing treatment for substance use. That included 28 million with alcohol use disorder, 18 million with an illicit drug use disorder, and 6.5 million with both. Isn't it interesting? We understandably focus on the opioid epidemic and now the meth epidemic, but we forget that still the number one disorder is alcohol use. Next slide. Over 97% of those 41 million didn't believe that treatment was necessary. They don't understand that there is a problem there. In 2020, just 2.7% of people were receiving treatment of any kind. I can't imagine that that's true for many other disorders. And in March 2020, really prior to the COVID, opioid overdoses jumped 18% compared to the same period the previous year. And as we know, they continue to rise in New Hampshire. Overdose deaths involving any drug rose by 30% in the first year of the pandemic. So what's the issue? How do we find quality treatment and how do you determine the level of care so that you believe you are doing the most efficient, most appropriate decisions? So first, what's quality treatment? There's 5 signs of quality treatment. Number one, you have a licensed program or a certified program. Then the staff are qualified and receive training on those particular topics. Not just one time, yeah, I went to a training years ago, but ongoing treatment. There are many changes in the substance use and behavioral health fields, particularly in terms of appropriate forms of treatment. And we want people to be up to date on those. So when we talk about training, we need to know that they're receiving training on things we've heard about: motivational interviewing, cognitive and behavioral therapy, dialectical behavioral therapy, both psychoeducational forms of treatment and group therapy. We want to know that they have medication available. Does the agency offer FDA-approved medications for recovery from alcohol and opioid use disorders? People go in, and we're not just talking about MAT, for example, but do they need something to help them with withdrawal? Are there medications available? Otherwise, you're splitting care. And in some cases, that might be appropriate. But for the most part, for people entering treatment, we need to be as efficient as possible. Because remember, 97% of the people don't think they need treatment. So if we delay it or we make it segmented in some way, we're more likely to lose them. We want to make sure that those treatment facilities offer evidence-based practices. These are treatments that are proven to be effective. So there's a fair amount of research that has been done on those particular types of treatment that indicate that those are effective for not just behavioral health, mental health issues, but substance use issues. And we know that some in combination are even more effective. Cognitive behavioral therapy is incredibly effective for these populations of patients, but cognitive and behavioral therapy with an understanding and a use of motivational interviewing has proven to be even more effective. So we want to know that the staff of the treatment facilities are aware of this, knowledgeable about these techniques, and actually know how to use those practices. Does the program involve the family? The agency includes family members in the treatment process. As we know, family need to be involved. They can either help the recovery or they can hinder the recovery. And interestingly enough, I know when we do our family component, family members expect that they're going to come in and they're going to have an opportunity to offer complaints and concerns about the identified patient. What they don't understand is we spend a lot of time talking about their engagement, how they impact on the other person's recovery, the family member's recovery, but also how they are impacted and how they can help themselves to change. One of the things that I believed for a long time is that at the root of most substance use disorders is codependence. And we need to be able to address that both in our treatment facilities and with our family members. And supports. Do they offer ongoing treatment and supports beyond the substance use issues? Do they have recovery support workers who can continue to work with them or maintain that contact? Do they maintain that contact? Do they do any follow-up calls to assess how people are doing and where they may need help? Do they offer help? Do they offer case management, for example, which might offer help with housing, obtaining benefits, any kind of recovery supports? And then we look, once we know what the signs of a quality program is, we want to look at assessing individuals. How do we assess people's substance use disorder? How do we know what we're dealing with? It's not just a question of, do they use? Oh, well, then clearly they need this treatment. We need to know not just about their patterns of use, but other factors. And we're going to talk a little bit about those. So determining the level of care requires a comprehensive assessment by a treatment professional, someone who has been trained to do these assessments on all levels, to determine that the level of care matches the needs of the individual. And you're going to hear me say that quite a bit, that we're looking at what matches the needs of the individual. I'm going to keep falling back to that 97% that don't believe they need treatment. So we need to find out what are their needs, what are their perceived needs, what are their projected needs, potential needs, and figure out how we can meet those, because that increases the likelihood of treatment completion. Okay. So the first dimension, acute intoxication and withdrawal potential. Have they gone through withdrawal before? What substances have they gone through withdrawal? For example, we're much more concerned about alcohol withdrawal than we may be immediately about others. It's not that we're not serious about other forms of withdrawal, but we know that people can die from alcohol withdrawal. So we have to really pursue, what has that been like? What were the substances? And they may say they don't know, so we get as much information as we can. If they've gone through withdrawal before, what was that like? What were the symptoms? I've asked in my intakes, have you gone through withdrawal? What was it from? What was that like for you? And what I typically hear is, oh, it was terrible. I felt like dying. Okay, tell me more. What were the specific symptoms? And then we get a broader understanding of what those symptoms were. The nausea, the abdominal pains, the aches and pains, the inability to sleep, and a broader expansion of those symptoms, because we want to be able to address those symptoms in treatment. We may need to know those if medication is required. We want to make sure that the medication we provide is appropriate for those symptoms. So what was it like? What were the symptoms? How long did they last? And what was it they were withdrawing from? Get as much information as possible. They may say, it wasn't bad. It was like a bad flu. Okay, that doesn't mean the next withdrawal is going to be like that. But we need to get as much information as possible so that we can make the appropriate steps to make this as least painful as possible, while at the same time understanding what substances really require a withdrawal protocol and which may be desired, requested. But there's a difference. Doesn't mean we're going to withhold anything, but we want to know the extent of their withdrawal. Okay. Oh, and some of that withdrawal, we think withdrawal, for example, and we think that has to be in a hospital or in a detox center. There are a lot of substances that can be monitored on an outpatient basis, including alcohol, depending on past symptoms. So the second, biomedical. What are the biomedical conditions or complications? Are there any other medical conditions that require immediate or ongoing care. For example, we are currently pursuing, and this has been coordinated in Nashua also, but we are currently pursuing bringing people into a treatment facility who have endocarditis. So they may be in the hospital for up to 6 weeks, and they are ready for treatment, but they have endocarditis, and we don't want them just sitting in the hospital when they could start their treatment. But we have to take into account all of the conditions, all of the physical conditions of the endocarditis and what it means and what the medical care is. We also have to be aware that they still have access to drugs and how that will impact on that. And what are the other medical conditions that require immediate or ongoing care? Does the facility you want to refer them to have the ability to provide that care? Is there skilled nursing? Is there a doctor on call or a doctor who will make daily visits? You have to know what those conditions are before you can make a skilled decision about that. What are the emotional, behavioral, or cognitive conditions? So, is there a co-occurring mental health diagnosis? Now, I have to tell you that it's rare, in my opinion, when people come in requesting or looking or being assigned, mandated for substance use treatment, that they don't have a co-occurring mental health disorder. They're depressed, they're anxious, they're fearful, they have PTSD, the whole gamut, ADHD, we see a lot of those. Sometimes if we accept the fact that people use substances to either receive pleasure or reduce pain, that's frequently related to those mental health symptoms. So we have to identify what those are so that we can make sure that those symptoms are addressed also. It almost seems ludicrous to me to separate and just provide substance use disorder treatment and never address the mental health. Because if you're depressed, you can go through treatment, but if you're still depressed and it's never been addressed, it's never been treated, that's more likely to trigger your use again. You have to address both of them. What are the symptoms of those disorders, those other conditions? You have to look at developmental issues. We frequently, because we see a lot of people who are homeless or recently released from jail, we see a lot of people who have literacy issues. You need to be able to know that to make sure they receive appropriate treatment where they are going. If that treatment facility includes a workbook, are they going to have help with those workbooks? If it's mostly psychoeducational, that treatment, and they're given worksheets to complete between groups or after dinner, are they going to receive some help? Is it possible to receive some help? Because otherwise, frequently people who are illiterate don't want to acknowledge it. They'll make up other reasons. Oh, I left my glasses at home. I can't complete this. Or, you know, I'm having problems with my eyes. When the truth is they can't read, they can't write. So we have to be able to assess this to determine what treatment we are going to offer them and is it going to be effective. Imagine going to treatment that you're ambivalent about anyways, and now people are making it harder for you because you have to find a way to complete these assignments. And if you can't, you give up. And unfortunately, they're labeled as non-compliant, when the reality is it wasn't an effective treatment for them. So we have to look at those issues. Okay. Readiness to change. You know the stages of readiness. Pre-contemplation, they're not ready. They're not ready for treatment. That's that 97%. They don't need it. But that doesn't mean treatment can't be valuable for them. It doesn't mean that treatment can't change that stage for them. We get a lot of people, as I say in our programs frequently, I don't get many people who come in or ask for an intake and say, I can't wait. I've been looking for this. I've been looking forward to this day. That doesn't happen. Most of the time, they seek an intake because my spouse, my boss, my children, my friends, court, my lawyer tells me I have to do this. So they may not be ready, but the fact that they are calling and asking for help, there's your moment of hope. And we have to be ready to seize on them. It's dangerous to say they're in a pre-contemplation stage, and so they're not ready for treatment. Then they get to the contemplation stage. They're getting ready. So now they've begun to realize that there may be things going on in their life that are not as effective or helpful or are more harmful than they have been ready to admit. They still may not think they have a substance use disorder. That's okay. We don't have to label them as you need a substance use treatment. We can merely acknowledge and work with them in saying, you need some changes in your life. So we're going to help you learn how to make those changes. So they're getting ready. And then you have people who are ready, the preparation stage. And these might be individuals who have been in treatment before. They've been in treatment in the pre-contemplation stage. They've been in treatment in the contemplation stage, and they still had reuse, or some of their symptoms haven't gone away. They're still being triggered heavily, or family members are still saying, nope, this is still not okay. They're tired of that. And so now they're ready to take it seriously and really make some changes. As they've gotten treatment, now they're ready to move, they're ready to make some changes, they're seeking out ways to change, they're in the action stage. And then the maintenance stage is, how do I keep this going? I'm still having these struggles. How do I make those changes? I've noticed that this is starting to bother me. I've noticed that maybe my depressive symptoms are returning. What do I need to do to sharpen my skills? And then relapse, continued use or continued problem potential. Have they relapsed before? This is incredibly important to look at this. As I always say, a reuse is certainly not a sign of failure. It's certainly not a sign that you didn't do everything you were supposed to be doing. But we have to look at the particulars of that. Have they relapsed before? What was that like? How long did they relapse? How did they relapse? What were the triggers? What was going on, not the day they relapsed or they reused? What was going on for days before they reused? Because it built up. What were they doing? Were they going into the grocery store and kind of leisurely strolling down that alcohol aisle? Were they going back and hanging out, making overtures to friends, or noticing as they're scrolling through their phone contacts, particular people's names and beginning to relive? How did that reuse happen? There are always steps that have taken place that they may not have even recognized. What happened before the reuse and what happened after. When they started reusing, what did they do? Because it's likely that this is how their reuse is going to occur again. There's something in their triggers, in their repertoire of triggers, that they haven't eliminated or haven't addressed. Or maybe a new set of triggers occurred that they weren't prepared for, that took them by surprise. And so what can we help them with? How do we do that? It's a sharpening of skills. It's not a failure. It's not a failure of treatment. It's not their failure. It's a sharpening of skills. So we have to ask those questions, not only to understand maybe what level of care they need, but also to, when we make those referrals, to inform the treatment providers These are the things that you're going to want to pay a particular attention to. So this makes us better referral agents. Okay. Recovery and living environment. Where do they live? What's their living environment? Do they have support? Are they around family members who are supportive of them, who don't use or don't promote alcohol use or drug use? Or are they living in a situation in which it is rampant and it's a struggle for them every day to look the other way or to avoid those messages? Do they have support? That's one of the reasons that family support is so critical, so that family members, and that's an extended family. It doesn't have to be biological family members. It's the friends that they are with the most. It's their, if it's their work environment, then bringing a coworker, whoever is going to be their support people. We need to help them help the person with the substance use disorder. So teaching people that asking someone with a substance use disorder, so how are you doing today? Are you wanting to drink today? How you doing? How's it going? You having triggers today? Is not necessarily helpful. If we're trying to help them move on to focus on a new life, constantly bringing back the old life is not necessarily helpful. At the same time, we want people to be supportive and offer them help in changing those skills and changing those techniques. We also want them to be in an environment where, for example, family members are not still angry with them. They may be angry, but we have to help the family members to understand that they need to work on those issues, and perhaps still voicing your anger about, yeah, well, you used, well, you disappeared, isn't helpful. We want them to be as supportive as possible. But first, in order to make those suggestions, both to the individual and to the treatment center, we have to know what they are. So we have to know what their recovery and living environment is. Who do they live with? How old are they? What's their substance use patterns? What kind of interactions have they had around their substance use? As many details as you can have, all leads to that client's success. So remember, as you're going through all of this, the first step in motivating people towards treatment and recovery is for you to believe in it. You have to believe that this time may be their success. I've done assessments for people who have been in residential care 6 and 7 times. And it's easy for them to lose hope, and it's easy for us to lose hope. But we have to know that they came back, so they're still willing to look at it. They're still willing to change. And how can we help them maintain that hope? Maybe this is the time. Maybe this is the time they get those magic words that really click with them. Okay. So then we look at levels of care. And as you can see, there are several. Many people aren't aware of all of the levels of care. And so we're going to go through those, from early intervention services to medically managed intensive inpatient services. And if you have any questions, don't be afraid to put them in chat. Okay, next one. Which level of care is the most appropriate? The answer is, it's the level that meets the needs of the client and provides all of the criteria of quality, effective treatment. We forget about the needs of the client. We think about the substance use. We think about the use. We think about the consequences of the use. And we decide typically the most severe treatment because we want to feel safe. We want them to be safe. But we really have to look at the needs of the client. Again, I'm going to refer back to that 97% who don't believe they need treatment. And if you don't listen to what their needs are, they're going to stop listening to you. And it's likely they are not going to be as successful. So we really need to ask them, what do you think you need? What's going to be the most helpful to you? And to really assess their answers and evaluate their answers. For example, do they need to work? Can they afford to be out of work? If they can't, if they're the sole source of income in that family, then what's going to happen? How likely are they to maintain treatment if it's keeping them out of work and their family is going to suffer? Not likely. Are they responsible for childcare? How likely are they to continue treatment if it's interfering with their childcare and maybe they don't have anybody else to provide that childcare? They may already be feeling guilty because of the impact on family members. And so now, if we put them in a very restrictive treatment environment, that is not going to help their guilt. And so they may prematurely quit treatment. We need to think about those. What are the needs of the client? Okay. So the first level is level 0.5, early intervention services. Early intervention provides education, resources, and counseling to individuals at risk for substance use disorder, but who don't meet the diagnostic criteria under DSM-5 or DSM-5-TR. So, for instance, a person who may be misusing alcohol and drugs, but hasn't developed an addiction. The easiest example that comes to my mind are college students who go away to college and overindulge and misuse. Some of them do develop addictions, but not everybody. And so when we see that misuse, particularly it's likely it comes to our attention through consequences, we address that. We provide counseling, we give them education, we talk to them about the course of misuse that can lead to addiction. We may ask them about family genetic components so that they can see they're likely to develop an addiction, and we give them resources. Here are some things you can do. Here are some precautions. Here are some warning signs that we want you to be aware of. So it's that first step of, yeah, this is a potential here. We need to look at this, keep an eye on it. But it's not a long-term care. Level 1, outpatient services. Fewer than 9 hours of service a week. So they may see somebody individually, they may see a medical provider for medication, for example, for anti-anxiety or antidepressants. This is administered by addiction professionals or trained clinicians, although it can certainly include recovery support workers. It includes evaluation, treatment, and recovery follow-up. And treatment typically provides, again, medication treatment, group or individual abstinence counseling, relapse prevention, and drug and alcohol education. Particularly relapse prevention. So these may be people who, by and large, have successfully completed treatment and have done very well, but had a recent reuse. And they want help before that goes any further, before it develops any further. So a relapse recovery group might be helpful, where again, they have a refreshment of the skills that they learned. Those are outpatient services. And the next one is intensive outpatient services, IOPs. This is 9 hours or more a week. The recommended minimum duration for IOP is 90 days, 9 hours a week, 90 days. It provides group and individual abstinence counseling, relapse prevention, and drug and alcohol education. So in our program, for example, we meet Monday, Wednesdays, and Fridays for 3 hours, and it's 90 days. And they learn, it's co-occurring, so they learn not only how to prevent reuse. They learn about drug and alcohol. They learn about addictions. They also learn about how to handle anxiety, depression, ADHD, how all of those impact on their use. We have a family component. We bring all of those components in 9 hours a week. And then in addition to that, they may see somebody for meds. They may see it in our program. They may go to their primary care provider. We work closely with them. So 9 hours a week, usually more substance use counseling than an outpatient program. And it's designed to meet multidimensional needs of people with addiction and comorbid conditions. So there's usually recovery support factor to it, and case management factor. So we work, for example, with our recovery support center, who does a peer support group as part of our program. 9 hours. That's can be the beginning of their treatment, where they're just recognizing that they have a problem and this can help and be enough. Or it could be they've had more significant longer-term residential care or partial care, and now this is a lessening. So they're not ready to go from a higher level of care just back into the community. This lasts a little bit longer. It helps them ease their recovery transition. Okay. Level 2.5 is partial hospitalization. This is 20 or more hours of service a week. Doesn't require 24-hour care. It's pretty intense. It's at least 4 hours a day, and it's all groups. During that time, they may also see a medication. They'll be evaluated by a medication provider, a medical provider. They may be prescribed medication. They may be started on MAT, for example. These are individuals who live with unstable psychiatric and SUD conditions. And so you may have people who are suicidal, but don't require inpatient hospitalization. They have those thoughts, and we're going to help focus on how to address those thoughts on a daily basis. It's delivered by an interdisciplinary team of providers, medical providers, nurses, M.B.A or licensed clinical mental health counselors, case managers, recovery support people. And it includes individual group counseling, educational groups, motivational enhancement and engagement strategies, family therapy, and other skilled treatment services. So we have a family component where family members can come in with their member who is in the treatment program and learn about the addiction and learn about what they can do for themselves and for their loved ones, because we think that that's critically important. Many programs are co-occurring, and that's why they can address both psychiatric and SUD conditions. In a partial hospitalization program, because it's 20 hours a week, some of them are in the evening, so people can work during the day and come in the evening. Some of them are during the day, so they can either work a part day, or if they're working in the evenings, don't miss any work. But it's critically important that they have that intensity of care. The great thing about IOPs and PHPs, I think, for example, is that we learn the skills, we learn what we need to do very specifically. What are you going to do? There's preparation for a return home that day. What are you going to do? What are the triggers? What do you have to watch out for? And then the next day they get to come in, and the first thing they do is review. How did you do? And if they did well, they get some praise. That's great. You've learned new skills. And if they didn't do as well, then we give them the support. What did you learn from that? You were triggered. So what have you learned? How can it be easier? There's immediate examination of a renewal of skills and what they can do differently. And there's preparations for days when they're not in treatment, like weekends. A lot of preparation time, very intensive. Okay. Then there's level 3, residential inpatient services. Residential services typically provide a 24-hour living support and structure with support from trained SUD treatment, mental health, and general medical personnel. Low-intensity residential services include at least 5 hours of clinical service per week. So it's not as intensive treatment as they may get in intensive outpatient or partial hospitalization. But this level of care can be really important for people who live in a dangerous home environment that is going to constantly trigger them. Think about people who may be homeless in homeless encampments where there are lots of people surrounding them using drugs, or they're in a family where there are lots of people using alcohol and drugs and who may be offering those substances to this client. It's not going to be helpful for them. For those individuals, a break into a residential treatment center can be helpful. And they have to focus on, where do you go upon your return? Can you go back to that home site? Do you need to find other places? Can we help you finding those places? If you have to go back to the home site, how can you cope? Developing those skills to be able to do that. So again, services include medication management, recovery skills, relapse prevention, individual, group, family therapy, and case management. And there's a lot of social skills as they have dinner meals together, maybe have a recovery meeting. They typically have homework that they have to complete. This has to include credentialed medical, addiction, and mental health professionals providing services. These are all certified levels of care, so there have to be professionals there. Next one. You have level 3.7, medically monitored high-intensity inpatient services withdrawal management for adults. This is 24-hour nursing care in an inpatient setting with an available physician. Patients require medication and have had a recent experience with, not being able to complete a withdrawal management program. So they've been in detox and haven't been able to manage that. It may be because of physical issues, and so they are requiring an inpatient setting to look at their medical issues, to look at their substance use, to look at their mental health services. Okay, next one. And then we have level 4.0, medically managed intensive inpatient services. This is 24-hour nursing care and daily physician care for severe unstable problems, commonly known as detox. It's generally provided in an acute care general hospital, an acute psychiatric hospital, or a psychiatric unit within an acute care general hospital. The length of stay is sufficient only to stabilize the acute symptoms. So the primary focus is case management and care coordination. Where are you going to go after you leave here? It's a referral. We're trying to coordinate referral to another level of care. It's important to remember that detox is not needed for every client. It is not needed for every substance. I was in a recent task force meeting, and the physician who was present was surprised when she heard us talking about people who are going to detox for opiate addiction. And we had a short discussion about how important detox can be for alcohol withdrawal, but not frequently medically required or medically necessary for opioid withdrawal. One of the reasons we send people to detox is because people are requesting it. They know how miserable withdrawal from opioids, for example, is, and they don't want to go through that alone. Some of that is largely as the providers, issue, and that we've just generally referred them to a detox center instead of trying to manage it from an outpatient basis. I worry, for example, that we're sending them the same message as their addiction sends them. If you have a problem, if you're uncomfortable, there are pills for it, and you need an inpatient stay. I'm more comfortable looking at what are the services they need, what's the severity level likely to be, and can we help you get through that physically and medically without an inpatient stay, unless it's warranted to have an inpatient stay. It's also important to remember detox is not treatment. So again, we hear many clients say, I don't need treatment, I'll go to detox and I'll be fine. I'm not quite sure what that means. You're going to feel better after your withdrawal, but you're not learning any of the skills that you need. And that's our responsibility to help them understand that. That if you're in detox, it's a very short period. It's a very short stay. It's just enough to stabilize your symptoms, your physical symptoms. And then you're going to be released. And guess what? We're going to recommend that you go to treatment then. The issue may be once they're past their withdrawal symptoms and are feeling more comfortable, they may not feel the need to go to treatment. So we have to have those conversations. It goes back to that discussion of what's the needs of the client. Okay. How do we decide? You take into account the criteria for quality treatment. You take into account the different levels of treatment and what programs provide. It's important that we become informed referral sources, that we know particular programs and what they provide, not just what type of treatment they offer, but what exactly do they provide in that treatment. And treatment centers are always happy to talk about their programs. So you may want to call or ask them to come in and do a little training on what they offer. But we always look at what's the least restrictive level of care first that meets the needs of the client, physical, emotional, psychological, social determinant levels. Which level meets their needs, the client's needs, not the needs of others. When we have a parent or a spouse or the court saying, we need them to be in this level of care, that we're not mandated to meet those needs of others. We are mandated to meet the needs of the individual who needs the services. What can you do? I say this every time I do a training because I think it's so important. When we utilize our resources, finding out what's available in the community, provide positive reinforcement, believing that they can do this, providing hope to them, and helping people with kindness and respect, we increase their chances of getting well. If you can give the message that I think this treatment will be helpful to you, this is what I think will be helpful to you, I know you can do it, these are the skills you're going to come away with, they believe because you're the expert. So if you believe, they're more likely to believe. We need to be able to give the positive reinforcement and the hope to the people that we serve. Next. What more can we do? Don't be afraid to ask questions, to encourage conversations and raise awareness of what's out there and what they can do. Don't be afraid to talk about the illness, both the mental health issues and the substance use. They are illnesses just like any other illness, and we need to be able to raise those questions. We need to be able to give the perception that this is an illness, just like any other physical illness that you have. Let's talk about it. Raise issues non-judgmentally in relation to their current medical concerns, the same way we would with anyone else or any other illness. Accept what the patient is ready to do or consider. Hard sells don't necessarily work. They build up resistance. They're more likely to say no, or they'll go along with it, but they may not continue. And then focus on their recovery and their improved health. This is what you have to gain. This is what you're going to learn. This is what may be easier for you the next time. Wouldn't it be nice to do this? Wouldn't it be nice to be able to celebrate a birthday celebration with your child and not worry about it, for example, if that's been one of the issues that they talk about? Okay. And then remember, they may not seem like they're hearing you or responding, or maybe responding the way you'd like them, but they carry your words and attitude with them when they leave. If you believe in their recovery, they're more likely to believe in their recovery. And it gives them hope and motivation to continue. You can even warn them when you go to treatment, there may be times when you begin to get resentful or think this isn't going to work. Bear with it. Stick to it. You'll get through those times. Ask for help. Tell the people in that treatment center that that's the way you're feeling. That's how you get better. In fact, the fact that you may struggle at times is a sign that you are working at it. So you have to continue to give them that hope, continue to give them that belief that you believe they can recover. And that's it. Any questions?
Please feel free just to unmute. We are a small group today, so just feel free to unmute and ask your questions.
Hi, Carol. This is Susan. Thank you very much. That was a wonderful presentation and so well organized. I have to say, you really got my attention at that 97%. And being a facilitator of a family support group where families obviously always recognize that this is a bad issue getting worse, and this 97% of them aren't thinking it's a problem at all. What hints do you have for family members to initiate? I can see where someone gets arrested, incarcerated, they're coming out. Sometimes they're just forced into treatment, but wanting to be a little bit proactive before that happens. What could families say or do to encourage treatment for their loved one?
The first thing I would suggest for family members is to come in and talk to somebody about their needs and what are the issues for them. They need that support before they can go anywhere. I want them to have the support that they need and then learn how they can address it with them. But it's not about them. It's about my need as a family member. And I'm entitled to say that. They need to hear it. If we make it about, you need to do this, you need to do that, they're going to argue with you that they don't. They don't need help. 97% don't need help. You're the unreasonable one, right? You're the one who can't let it go. You're the one who doesn't understand. And so you can make it about you. I'm uncomfortable. I'm sad. I'm worried. This is what I need to be able to live in this situation. That's assertiveness, but they need to hear that. Sometimes that's the only way they hear the consequences, to hear how it impacts on you, because in their mind, it doesn't always impact on them.
Right.
Yeah. Take care of your needs as a family member. Listen to that.
Other questions or reactions? I'm seeing some folks with a lot of background in different disciplines in the room. And in the sense of one question I would have for probably Carol and Lindy, who have a lot of experiences, to some others in the room, how well does it work? This is a pretty elaborate triage process, and I'm just wondering if, in the practical sense, if there is a way to improve it, or if this is something that can work really well in the hands of a competent practitioner.
How well does it work? The assessment process, the referral process? Which part? All of the above?
I'm a whole systems person, and I'm kind of interested how it all fits together to get that person into treatment. And I'm also thinking that the last time we saw you was June 16th, where we spent a good session on stigma reduction. And I think these two things are so closely linked. And your closing comments about they take the attitude with them that they encounter resonate with me. I mean, you create that environment. Normally we say, you know, it's up to the patient, but it is so important to be mindful of that too. But I'm interested in how you see the whole arc of the system working from first encounter into hopefully some kind of recovery beginning?
I think this is me, and I'm an eternal optimist, I think. I think that 100% of the time recovery begins because you plant seeds.
Mhm.
I can't emphasize enough. What you say plants the seeds, and they're going to carry that with them.
Mhm.
Whether they listen to it this time or not, they carry it with them. So I think the process can work very well. You know, we have people who do intakes and we schedule them to start treatment and they don't come. Okay.
Mhm. Mhm.
But more than likely they call again and they schedule and maybe they don't come. But the third time they come. Why? Because we don't say to them, yeah, sorry, you didn't show up the last 2 times. You're not
Mhm.
coming this time. Absolutely. Our doors are open. When you're ready, we are here. Regardless of what the issue was, we're here. We're ready when you are. So I think you have to make that opportunity available to them. I've been in the field for a long time, and I remember 40 years ago, the philosophy, Linda, you may remember this, the philosophy was they come into treatment, you break them down, right? A lot of shaming and blaming. You had to break them down to ground zero and then build them up in order to start their recovery process. Well, thank God we lost that philosophy,
Mhm.
hopefully at least, because I don't know of many successes that result from making people feel worthless. That doesn't build hope that way. So we have to give them hope. We have to help them understand that this is possible. If they haven't had the skills, then we're going to help them get the skills. We have to change their language. Lindy and I talk about this all the time. I recently was in group and someone kept referring to themselves as an addict. And I said, please, I'm asking you not to do that. Addict, maybe that's who you were in the past, but that's not who you are now. You're in treatment. You're starting recovery. Let's talk about you as someone in recovery. And her whole face brightened up. We have to be able to address that from the minute we meet them until the minute they complete the program. We have to look at all of those figures. I would say, and some of you have heard me say this before, I'm obviously biased, but I would just want people to be mindful that residential care is a needed level of care, but it's not for everybody. Not everybody needs it. Some people live in very supportive home environments. People want to help. They will be there to be supportive. They have jobs. There are no safety issues. And yet we expect people to, it's almost a knee-jerk reaction. Well, you're going to go to residential care. And then we wonder why people say, well, no, I'm not going to do it. Well, maybe they can't. Maybe they have to work. Maybe they have to take care of children. Maybe they have other needs, but another level of care could still work. So that's my concern, that I think many people just know about residential care. And there are other wonderful levels of care that are very successful. If I had any concerns, it would be that we broaden our horizons a little bit.
Carol, I really appreciate your comments about family. I think that's just such a critical component of recovery, and that at every level that they should be brought in so that they're continually educating themselves on the disease and what they can do and their responses and how they react to different situations, how they handle setbacks and relapses. All that stuff is just so important to the ongoing recovery.
Yeah. I work a lot with Susan Vegsharter's family roles in addiction and talk about that with both the family members and with the clients in treatment, because this is such a predictable disease and it has such predictable results in many ways. I want people to understand that this is not unique to them. This is the disorder.
What's the name you just mentioned, Carol?
Susan Wegsharter, Wegscheider.
It's actually Sharon.
Oh, yes, you're right. Sharon Wegsharter.
Thank you.
Thank you.
Shannon has a question she's put in the chat. Shannon, would you like to come off and just ask that directly?
Sure, thanks. Hi, Carol. That was a great
Hi.
presentation, a great refresher on the different areas for the assessment. And I was just wondering, because my role working within primary medical care practices is, how do you think that this assessment could be better incorporated with a patient's primary medical care?
I know I'm preaching to the enlightened, but you start with SBIRT, screening, brief intervention, referral to treatment. And if there's something there that leads you to believe there may be a bigger issue, I think primary care is a perfect opportunity. They're ready, more willing and ready to talk to you about physical symptoms and environmental symptoms. I think we just have to ask. And as they talk about it, I mean, time is limited, I know, but as they talk about it, get more details from them. When are you using? When are you drinking? How much? And then, you know, what are the consequences? Whether you agree with them or not. How do family members feel? Have you had any problems at work? What are your thoughts about treatment? And if they say, oh no, I don't have time for that. Okay, tell me why. How would it get in your way? You're going to know, hopefully, more about the comorbid physical symptoms. You may know about the mental health issues, but it doesn't take a long time to do this. If you ask very focused questions, you get very focused answers.
True.
Mhm.
True. Great. Thank you.
Sure.
My question comes from my position here. We're working hospital-wide, and how well equipped do you think primary care providers are to do what you say?
Not very.
Okay.
I think, again, if you realize that in medical school, most medical providers receive an hour or less of training on substance use disorders. They're not aware of it. They certainly don't understand treatment. They don't understand contingency management techniques. They don't understand cognitive and behavioral, but even more than that, they don't understand the disorder. They don't understand the disease. And it's really up to us as professionals to address this with them. You know, as we all know, my first step was in trying to address stigma, and that was pretty successful, but now I have to go back and train and educate more about not just treatment, but what they're seeing, the social determinants, the consequences in the family, and what they can do. I think that when I first went out and started talking to medical providers, they said, I don't know anything about it. I don't know what to do about it. I don't even know if I have those patients in my practice. And I, without much fear of being wrong, said, oh, I can guarantee you do. So let's find the right questions for you to ask, or let's look at the right signs, some of the signs for you to look at that might be indicative of it. Once they can do that, and once they have a resource, I'm not asking them to treat it, but I want them to recognize some of the signs and know where the resources are. We still have a lot of work to do with primary care providers, I think. Shannon's nodding, having worked with a primary care provider.
We're all nodding.
Yeah,
This is our workspace.
right.
I can comment, Dan, on that. I think that is such, I mean, that is an important piece to remember, that both the primary care and the emergency rooms are the first places that people turn to or may turn to when they're not met with the kindness and the understanding of the disease that is a barrier to treatment. So it's a really, it's just an important piece, because to get to that level of assessment means requires that the people that the patients are trusting the providers, and if they've disclosed to their primary care person and that person doesn't know what to do with that information or does it wrong or further stigmatizes. It's tough.
Or doesn't know the questions, doesn't know the questions to ask. And so the questions they ask are stigmatizing in themselves.
Mhm.
And you can see that the patient shut down.
And I would say too, as family members, we're often, that's also where like that, that's where I first turned, was to my primary care physician to say, I think my son's in trouble. What do I do? You know, a lot before I was involved with all of this and now know somewhat what to do. But, you know, so even with that, it's, you know, and they're like, you know, not sure. So it's great work. Thank you, Carol.
Yes, thank you for all your work. We're so glad. I said that you, so glad it was the best news of 2022 that your retirement didn't mean that you were withdrawing from the field, because we need you. And we know that you are a subtle but very effective influence upon the healthcare system in which you work, and that is a model. And I'm thinking about the successes of places like Dartmouth Hitchcock, Wentworth Douglas, and others have, and having these Exeter, and having these incredible providers who are champions for this work. And it means so much within that environment to bring that in and say, to have somebody who says, you can do this. It's that entire thing about peer providers providing this kind of motivation. It's so powerful. And thank you for what you've done. The Elliot story is a good one.
Thank you. Sometimes not so subtle an influence.
Yeah, subtle. I might have to withdraw subtle.
Thank you.
There is a difference between quiet and subtle. And I'll say sometimes you're quiet. You don't raise your voice. But as my daughter told me one time, when I told her her mother was subtle, she said, "Mommy is about as subtle as a pink llama." You know, so you're a quiet voice, but you get your message across.
Enjoy. Well, thank you. Thank you all.
Thank you very much. Any more questions, closing comments, observations? Thank you for joining us today. Thank you, Carol, for stepping in. We were working and lining up some presentations, and there was another presenter who fortunately was, with a few weeks of notice, was able to say that they couldn't make it. They will be coming back hopefully before the end of the year and presenting to us, but I'm going to go off script for just a moment for the folks at Growth Partners and tell you that the Community of Practice Planning Group is active. It is meeting. Getting these 6 people together for a meeting is probably the most difficult assignment I've had. But in addition to Carol, we have Ann Brennan from Dartmouth. We have Corey from Concord in Laconia. We have Monica Edgar from Concord Hospital. And we have a voice from lived experience. Karen McAllister has joined us. And Karen is working on her degree, undergraduate degree, with eternal objective of becoming a doctor of osteopathy and practicing within the substance use field. So we have a really tremendous planning group. We are meeting. Our intention is that beginning now, we are having monthly meetings, and we are going to brainstorm and plan out as far in advance as we can and begin to populate that so that we can get this on your calendars. We ask you too to continue in dialogue with us and let us know the kinds of things that institutions need, that hospitals need, that will meet your needs. That's a segue to going back on script and talking about our partners at Growth Partners and the New Hampshire Technical Assistance Center website. I'm sorry, it's late afternoon, right? Yorkie's had me up at 3:40 this morning. NHTAC.org. All of the recordings of these meetings, all of the presentation slides, everything is on there for at least the last couple of years. Our next meeting will be on October 20th. And we invite you to spread the word and within your organizations to, if you have not done so, join the community practice. You can do that through the website. Encourage others within your sphere to join the community. We'd really like to see it take off. As Carol indicated, my question was a leading question. There was a lot of work to do in this field. And the more people that know this and have access to it, the better off it is. With that, I think I have covered everything I have in closing, and I will ask our Forensic Growth Partners to insert an evaluation. Yeah, Stephen is on top of it. Thank you, Stephen. Please take a few moments as we close out to use that survey. And look forward to 5 weeks from today on October 20th, and we'll have some good programming for you. Are there any closing comments before we give you about 16 minutes back in your day? Okay, without that, we'll wish you a good day, and we'll have our FHC staff and Lindy and Growth Partners, and we'll just do a quick kind of review here. And thank you all so much. And we'll hope to see you on October 20th.